Hello, folks, and welcome to our Future of Healthcare Virtual Roundtable series. My name is Jacob Nicolau. I am one of the learning partners here at Mergen. I'm joined with some of my colleagues, Megan Frankel and Christina Yu, as well as the illustrious Dr. Graham Mooney from Johns Hopkins, a medical historian who is going to be talking about contact tracing with us today. Just as we let folks filter in, I would love to hear where you're from, how the weather's going. We really are delighted to have you here today. And we like to call these roundtables for a reason. We really appreciate it when folks utilize that chat function and get acquainted and interactive with our presenters as well as us. We are here to answer all of your questions. So while we're waiting for people to filter in, please do tell us where you are joining us from. We don't call these webinars, they're not really sit and listen. We want to have everybody actively engage in more ways than one. So let's have a look. So let's see. Oh, wow. Carmen from Knoxville, Tennessee, Chicago, Omaha, sunny Baltimore. We have folks from all over the country joining us. Wow. So if you folks are interested in a recording of this presentation, we're going to distribute it to the current attendees after the session. And I think that it's going to be, in just a second, we're going to get started. Well, hello, Jillian. Thank you for joining us from Nassau, Long Island. And Becca. Hi, Rebecca. All right, so I think it's time for us to get started here. So welcome again to our Future of Healthcare Virtual Roundtable series. Today we are having a wonderful guest who's giving us the opportunity to learn from him, Dr. Graham Mooney, who is going to be talking about the importance of empathy and soft skills in effective contact tracing. Graham is an associate professor in history of medicine, as well as an associate professor of epidemiology at Johns Hopkins and the Johns Hopkins Bloomberg School of Public Health, as well as School of Medicine, if I recall correctly. His recent book, Intrusive Interventions, Public Health, Domestic Space, and Infectious Disease in England, 1840 to 1914, examines the history of public health interventions such as infectious disease notification, institutional and domestic isolation, disinfection, and contact tracing. Despite contact tracing coming sort of to the fore in our recent sort of COVID times, it is a discipline with a rich history, and I'm very eager to learn from Dr. Mooney where it's been and where it's going. So thank you so much for joining us, and I'm going to now hand off to Dr. Mooney on persuasion and empathy, a medical historian's perspective on contact tracing. Thank you.
Okay, thank you, Jacob. I hope I'm unmuted. Thank you, everybody, for coming today. Strange times that we live in, so it's fantastic that you're able to join us virtually. As Jacob said, I'm a historian of public health and medicine, and part of my interests, or one of my interests, is the history of infectious diseases. And contact tracing is an important aspect of interventions around trying to control infectious disease historically. In fact, it's become a central aspect of all kinds of disease management interventions. So I think maybe 6 months, 9, 12 months ago, not everybody would have known much about contact tracing. We now know a little bit more, but that also means that it gives us an opportunity to think about the history and where it came from and how it developed and why it developed and why it looks like it does in the present. So what do we mean when we talk about contact tracing? Well, at its very most basic, contact tracing involves identifying people who have an infectious disease. You may also hear them being referred to as communicable diseases. People who have an infectious disease and their contacts, that is, people who may have been been exposed to the disease, and working with those people, both the person who has the disease and their contacts, to stop the future spread of the disease. Now, that's a very simple definition, seems very commonsensical and obvious, but it carries so many implications that are important for the way in which we go about managing infectious disease, but also managing our life, as we've seen, managing our life on a daily basis. So what the COVID-19 pandemic has done is caused a massive increase in the demand for people who are able to do the contact tracing. And you all maybe are all following how many cases there are every day. You know, there was a big peak in the spring, it went down a bit, and now it's going up in many, many places. And the people who are responsible for contacting individuals who have the disease and then finding out who their contacts are very much in demand. So training for contact tracers has, as a knock-on effect, has also become important. There are a number of places where the training for contact tracing has been done, but it's important to know that it's likely as we transition, when we transition into a new presidential era, that the expansion of contact tracing isn't going to slow down. And that's because most people see contact tracing as being the key element of encouraging people to comply with, adhere to, abide by, whatever you want to use, the sorts of social distancing recommendations and guidelines that we're all now very familiar with. And really what this is building upon what already exists in terms of contact tracing for other infectious diseases. I'm going to talk about that in a little bit as we go along. But the point is that the system already exists. Public health professionals, epidemiologists know what works in terms of contact tracing and managing disease. So this is really just building on what we already have. There needed to be no wheel reinventions going on here. So, as I mentioned earlier, a number of places have ramped up their training for contact tracing. My own institution, Johns Hopkins, Purdue, University of California, UCSF, and Houston are all amongst leading schools of public health and medicine who are contributing to the training of people who are going to be employed by local and state health departments to contact people who have had the disease and work out who else has been exposed. And again, this is based on, these institutions do this kind of training, and they usually do it in partnership with local health departments and state departments. And it's all now freely, any of you, if you're interested in it, in becoming a contact tracer, or just want to know what contact tracing is, you can go to the Hopkins website, for example, and register for a contact tracing course. I've done it myself, and it's very important for me to understand what contact tracers were expected to do and what they wanted to do, because I wanted to know how the history fit into the present. So we know it works, but it doesn't always work, if you know what I mean. There are serious problems and issues around contact tracing. And one of the issues is that it's very difficult to scale up very, very quickly a program like contact tracing. And we've seen in lots of different places, not just in the US, but also in Europe and where I'm from in the UK, big issues around scaling up, around getting the technology in place so that you can train people. Because you can't have people come into an office to do their training, everything's online. You need to set them up with software at home and working on laptops and so on. So it's been very difficult to get the contact tracing operation up and running. So there are scale issues here, even though we know that contact tracing does work. What are the challenges that are faced by contact tracers? Well, you have to give people unfortunate news. Nobody wants to know that they've got an infectious disease. You have to ask for information that's private and confidential. And in order to get that information from people. You need to build a rapport with somebody who you've only just got in contact with, okay? And you're handling important, difficult information, sensitive information. And the contacts may have very difficult life situations, and I'll talk about those when I talk about some of the historical aspects of this. Contacts might not trust the government or the public health system, for example, for a variety of reasons, which I'll talk about. And we learn by trial and error in some ways. You can't teach, or you can only teach empathy up to a limit. There's ways in which you can only cultivate your own empathy through doing, through experiential learning. So it takes time for an individual contact tracer to build up that skill set in order for them to be able to maximize their ability to get information out of people that they need. And as we're seeing, there's a surge in cases, which increases demand. It puts great pressure on the system. And also, people, they're getting tired with the pandemic, it's particularly in situations where, holidays are coming up and we're used to seeing family and friends mixing and socializing and sharing bread around a table. That makes it really difficult for people to cope with the demands of something like contact tracing. So they're the kinds of challenges we've got in the present moment. And we just want to acknowledge here the community engagement specialist in New York, Trace and Treat, Daniel Okper, who really helped us with putting together some of these slides. Unfortunately, he couldn't be with us today. And all of these things came together and struck me as a historian who teaches public health that lots of these things are incredibly familiar to me. And one of the reasons why it's familiar is that there's always been a tension between public health and the interventions and how people go about living their daily lives. So public health often requires people to give up their freedoms, give up your ability to go to a bar and have a drink whenever you want, your ability to go down to your local library and take out a book, your ability to to work on to earn a living. And quite often public health interventions request and ask of us to restrict those freedoms. One of the ways in which we can reframe that, I argue, from a historical perspective, and the ways in which public health professionals from the mid-19th century onwards have argued, is that in fact, these public health interventions, yes, they might be restricting your freedoms in some ways, but they're also giving you freedoms in others. Imagine what it's like, if you can, to 9 months ago, 12 months ago, where you had all those freedoms. So where you were free from the threat of infectious disease and pandemics. And so the freedom that we're really after is the freedom to live a free life. And you have to manage the infectious disease in order to do that. Okay, so public health professionals, when they were in the 19th century, when public health really became an important node of government activity, these were the sorts of arguments that they were seeking to make. They recognized that they had to restrict people's freedoms and how people live their lives, but they also said, hey, it also buys us that freedom if we control epidemics and pandemics. And we can only do that, we can only buy that freedom if we have effective infectious disease management in place. And one of the things, as I said, was as I've already said, is the development of contact tracing as a key aspect of managing infectious disease. And there are many ways in which contact tracing fits into a whole range of interventions, including, as Jacob mentioned earlier, things like hospitalization, infectious disease hospitals, or say tuberculosis sanatoria. People used to have their houses disinfected if they had an infectious disease, and their clothes and their property disinfected. And contact tracing was part of this whole sort of this whole package of measures, if you like, that emerged at the end of the 19th and early 20th century as formal government interventions to control infectious disease. But the realization was that similar to now, people didn't always want to do these things. They didn't want to restrict their freedoms in any kind of way, or the costs were too great for them to do that, to undergo these interventions. So what we need to ask ourselves are a bunch of questions around the development of the history of contact tracing in order to understand why it's important now. Why are these issues key and significant now? And we can think about this through what diseases has contact tracing addressed in the past. And it's not just, it's not just like what we would think of as airborne infections, as COVID-19 is. There are a whole range of different ways in which infectious diseases can be transmitted. And contact tracing has been, at one time or another, important for many of these. One would be smallpox. I'm guessing probably nobody in this virtual room has seen a case of smallpox because the disease was eradicated in the late 1970s due to a very rigorous vaccination program instituted by or organized and coordinated by the World Health Organization. But smallpox contact tracing was very important for smallpox because there was an intervention available. So what you could do is you could vaccinate people vaccinate contacts as soon as they became aware, so that even if a contact had already taken on the disease, you could still vaccinate them, and that would provide them with protection if they didn't actually contract the disease itself. So they may have been exposed, not contracted it, but that gave an opportunity to provide the smallpox vaccination. It gave public health people the knowledge. So contacts for smallpox were routinely vaccinated. That is another issue around coercion and around mandatory public health regulations. Scarlet fever, not a disease you hear much about now, but was actually quite an important killer of young children in the 19th and 20th centuries. Viral disease. That became important. Particularly when children were congregating in schools, when mass education became a thing in the later 19th century. Typhoid was also an important disease for contact tracing. Some of you may or may not have heard about Typhoid Mary in New York, an asymptomatic carrier of typhoid who was, she was a cook and a domestic, and she was found to have been communicating typhoid disease through her activities asymptomatically. Wasn't displaying symptoms of typhoid, but was transmitting it. Contact tracing, very important for that. Also, sexually transmitted diseases, venereal diseases, syphilis and gonorrhea, particularly from the 1940s onwards, when penicillin became important as an intervention, as a curative intervention. If you were able to access the contacts, then you could also give them give those contacts, should they develop the disease, a drug regimen in order to cure it. So that became very important. And then, of course, finally, HIV/AIDS from the 1980s onwards was a very important aspect of contact tracing. And one of the things that is important about HIV/AIDS, or one of the contentious areas around contact tracing for HIV/AIDS, was partner notification. And I'll just talk about that in a little while, because what are some of the notable contact tracing efforts that these sorts of diseases prompted? Well, one was to make diseases notifiable, reportable. So when you got an infectious disease, cholera, smallpox, scarlet fever, whatever, your private practitioner, the person who you went to for treatment or for information about what to do, became obliged to notify your local government, the local state health, local city health department, rural health department, whatever. And then they would work on doing the contact, tracing the contacts. So the task of making diseases notifiable, which began in the later 19th century in cities, states, nations across the West, is the key first step to contact tracing. If you don't know where the patients are or the people with the disease, you can't find a contact. So that was the main thing. Schools became very important as nodes of knowledge for contact tracing. So very quite sophisticated systems came into place for tracing contacts through schools. Now, I don't know about people here, but I'm old enough to remember, and hands up if you are, when you went to school as a kid, that every day, for at least every day, you would sit in the same desk, in the same classroom for the whole academic year. I did that. Think about that information from an epidemiological perspective. If you have an outbreak of disease, you've got kids coming in, one of them has scarlet fever, so, you know, little Janet who's sat in the back row on the right. You know who was sat next to Janet over the previous days and weeks, and so you can begin to plot out potential contacts that Janet had in the corner. And then you can go to their homes of those pupils and students and warn the parents and the siblings that they had a disease. And so schools were really important for contact tracing. It's one of the reasons why, you know, there's been worries about whether schools should be open or not in the present moment, because you lose knowledge about, you might lose the knowledge about kids when they're running it around at home or in the streets or in the park and so on. So that was a big contact tracing effort. Another was, and I'm just going to scroll forward here a little bit. Another was the development of what were called reception houses. These were places that were specifically designed for the contacts of people with an infectious disease. And what would happen is the health officers would go in to a home, say, you know, little Janet has got disease. The rest of the family have to go to this reception house, and they can stay there free of charge, bed and breakfast and full board, as we would call it, provided for the family, and, you know, even possibly the wage earners could go out to work, but they would be kept under observation. And so a lot of places began to cater to contact tracing efforts by providing specific spaces like this for contacts. And we've heard some examples of, you know, hotels being used to put up contacts in the present pandemic. Another thing, so that's reception houses, that's another thing. I guess the other main thing would have been, that was important, was the development of systems that were sensitive to the knowledge of a particular kind of disease. And this was really resonant for sexually transmitted diseases. And one of the things that developed from the 1940s onwards were as anonymized as possible systems for notifying contacts of people with sexually transmitted diseases. This is one example that was developed in Mississippi in the 1940s. And it came with a patient education form, what was called a patient self-education form, where people who, you know, ended up in the doctor's surgery or doctor's office with syphilis, say, you know, filled out the contacts, and then the contacts were sent this information in a plain envelope that came from somewhere in the state that was anonymized, and it was only, it wouldn't identify the disease to anybody. It wouldn't, you know, so, and I'm going to quote here from the article that actually demonstrated this system of confidential notices. So it doesn't reveal the identity of the suspected disease to anyone opening the envelope by mistake or to a suspicious husband or wife. So that raises those issues around the partner confidentiality. So these systems of notification were very important and significant. What problems could we face? And I'm just going to go through these very quickly. Although reporting of infectious diseases is very common, we're not all very familiar about or happy with our information about our disease being shared. You know, we're not used to that as patients. So that's one problem, is that people may resist consulting their physicians or even going for a test if they think that they might have a disease. People are worried about sharing information beyond government agencies. So we've had big tech being involved in the development of mobile apps for contact tracing. What happens if that information gets into the wrong hands? That's an important consideration. That's a problem. People, as I mentioned earlier, might not want to share information because for a variety of reasons they don't trust government, and that's a problem. But also, they're worried about the possible impact that contact tracing can have on your friends, relatives, and associates. From having to isolate, to not go to work, to prevent you from caring from some. If you're a primary carer of a child or a family member who may be ill. So they're the main problems that we can see, and they're also contact tracing is also part and parcel of a like, if you like, a system of regulations around social distancing and masking that people resent, and they see it as a problem, as traducing their freedoms to go about their daily lives. How can empathy make a difference in contact tracing? This is really important. Public health people in the later 19th century used to bribe people. They used to pay them. They used to call them bribes to get people to go into one of those reception houses that I demonstrated earlier. And there are some economic compensation packages around in different parts of the world for people who have to isolate. But I think we need to be empathetic in order to meet people where they're at. And I think for the contact tracer, empathy in and of itself is great, but it also helps you focus on the problem in hand, which is controlling disease transmission. It helps you gain understanding of why they might not, for example, want to share information. And I think finally what's most important is that in some senses it helps you become less judgmental as a contact tracer. So the issue at stake isn't why somebody contracted the disease. What was somebody doing? What was their behavior when they contracted the disease? Were they in a place they shouldn't have been according to local guidelines and so on? It takes the focus away from that and just, let's forget about that. Let's be non-judgmental about why you got the disease and focus on actually controlling and managing the disease. And I think empathy helps us understand that because it squeezes out judgmentality from our approach to disease control. So with that, I'm gonna stop, and I welcome any questions that you've got, and chance to answer your questions as we go on. So thanks for listening. I'm going to stop sharing right now.
Thank you so much, Graham. That was absolutely fascinating. I'm going to quickly take a look at the chat and see if folks have any questions. So I don't see anything coming up right this second, but if anything comes up, I will immediately ping you back, Graham. Thank you so much.
Sure.
So, oh, my little box moved over. So, thank you so much for that presentation, Graham. There's really an emergent question as to how these kinds of soft skills related to contact tracing and specifically empathy can be cultivated and improved, especially as the demand for contact tracers who are very skilled is both urgent and pressing, and the opportunity to train them in our newly remote world is becoming sort of increasingly difficult. So here at Immersion, we use virtual reality to answer these questions. While VR has become household verbiage that we're all familiar with, the applications are a bit foreign. What we focus on here at Immersion is neurologically replicating experiences without the risks and incredibly high stakes that we all know in the realm of healthcare, and especially in a field like contact tracing. The purpose of this is to bring more rigor to the practice of soft skills, which usually take years of practice, feedback, and reflection in order to be properly cultivated. We bring all the innovations at our disposal together to create practice that hyper-targets specific competencies. And the benefit of doing this is that you're able to achieve meaningful results in terms of acquisition of human skills, soft skills, things like empathy or motivational interviewing in a timescale that previously wasn't achievable. Oh, my PowerPoint, there we go. So we use the power of VR, the power of presence and plausibility to create an immersive experience and direct that towards the aim of learning. Immersion is the virtual environment where you practice those very, very difficult professional or interpersonal conversations, whether they're related to contact tracing, leadership, clinical interactions, patient management, or even certain kinds of counseling techniques like motivational interviewing. So here's how it works. Learners experience a simulation, a high stakes interpersonal situation, whether that's providing care to a special population, delivering bad news to a patient, communicating essential information to a coworker. Simulations allow learners to feel the stress of a real conversation and achieve a blend of safety and danger at once. The real beauty of simulation work is that the learner can try new things, make mistakes, and learn from them. It's dangerous enough to recreate even the physical feelings of stress that come from an encounter, the beating heart, the awkwardness, and the confusion, so that the learner is inoculated for those stressors before they have to face the situation in real life. The goal is that learners emerge feeling confident and prepared to handle a real situation. Just as modern surgical simulations or military simulations recreate physical dangers and create a thrilling sense of immersion, we use our virtual environments to recreate emotional and cognitive dangers so that when we encounter them on the job, we're prepared. And today we're going to be doing one of our contact tracing simulations. And our learner for today is going to be Joanne, and Joanne is a graduate student who from NYU who just did the Johns Hopkins contact tracer training recently. Thank you so much for joining us today, Joanne, and I'm looking forward to watching you in the simulation.
Thank you so much, Jacob. It's great to hear that there are actual tracers also who are here with us. This is realistic because I have not done this, and so I've just done the training, and you'll see what I'm going through.
Well, that's okay, Joanne. It's a training simulation, so just take it as a wonderful opportunity to practice a new and fascinating skill set.
Absolutely.
All right.
Wow. Lots of good tracers. Okay.
One moment. Oh, here we go. So I'm just going
Jacob,
to pop off of camera.
Were you ready for me to pop
Thank
in?
you.
Yes, thank you so much, Bennett. So I'm just going to pop off camera here. And my colleague Bennett is going to talk to you now, and he's going to introduce the scenario. And after a brief reflection, after you have the opportunity to go through, I'm going to pop back on and ask you how it felt.
Okay,
Sure.
great.
Yeah.
Thanks, Jacob. Just didn't want to interrupt you there. Hi, Joanne. We met just moments ago. Good to see you again. And I heard you sharing with everyone that you've just gone through the class, and so I just want to reassure you and remind you that that's the point of this, is that it is a training exercise. And I think that's the beauty of these roundtables, is that we can then open up the discussion and share some best practices after the simulation. So with that said, let's take a look at what you're going to be doing today.
Sure.
So can you see that slide?
Yes.
Great. So today, Joanne is going to be practicing as a contact tracer. She's going to be speaking with Linda Walker, who is a recent contact to a person diagnosed with COVID-19. Now, Joanne, you have not been successful at reaching Linda via phone, so you have now had to go to her home, all right? So your objectives today are to establish trust and rapport, address her concerns about exposing others, share information on next steps and best plan of action, and provide appropriate resources at your disposal. Do you have any questions about that?
No, that's very clear. Thank you.
Great. All right, Joanne. In just a moment, you will see an empty room, then you will see Linda. And so that's when your conversation can begin. She can see and hear you just as if you were sitting across the table from her. And so you're going to have that conversation. Just remember, I am always here for you. You could say pause simulation if you need to come back, ask any questions, use a lifeline to Dr. Mooney if we have to. But I think you're going to be just fine. And when you're done, just simply say end simulation.
Absolutely. Okay. I've got some other tracers I can ask too. Hello. Hi. Hi. Is this Linda Walker?
Yes.
Hi, Linda.
Hi. Yeah, you said you needed to speak with me about an urgent matter.
Yes. My name's Joanne Kim, and I'm a community engagement specialist with the Hillside Health Department. We have actually had some trouble reaching you by phone, so I just wanted to come by in person to see if you had a moment to speak. How are you feeling, by the way, today?
Well, I'm feeling fine. What is this about?
Sure. Well, I just wanted to discuss some personal health information with you. So before we go any further, though, I just want to make sure and verify we have the right person. So I have listed here that you were born in 1982, and you live on 1006th Avenue. Could you please confirm the day and month of your birthday?
Yeah, I guess. How do I know? I mean, you just kind of showed up here. How do I know that you're legit somebody that I should be sharing this information with?
Please excuse me. I'll show you my badge. So I'm a community engagement specialist, and so we come in person when we're not able to reach someone, and we have to speak with someone about a very particular situation that's going on right now.
Okay, I mean, your badge looks authentic. So yeah, my birth date is June 7th, 1982.
Okay, perfect. So thank you so much. So we just wanted to come by. We're here to help you and just offer you some guidance and explain about what's been going on. So right now, we have some reliable information that you were physically close to someone who has tested positive for coronavirus. Right
Really?
now,
Who?
yeah. Well, we can't disclose that right now. Unfortunately,
wait. Okay, hold up. Whoa. You were coming to my house and telling me that I've been exposed, that somebody's told you that I was near them, and you're not going to be able to tell me who it is? Why not?
well, we're not able to share that information right now. In order to, for a lot of people to be willing to disclose the people who they've been in contact with, we guarantee that there's anonymity. Also, I actually don't even know who that contact is, to be honest. But,
Wow, I'm sorry. This is a lot to take in, and I'm just trying to understand. I mean, I can't believe that somebody in my circle that I would have been around would be positive and not reach out to me themselves. I mean, how ridiculous is that? What kind of friends do I have? Ugh.
you know, it might not be a friend, by the way. It just had to be someone who was in contact with you within proximity for, it's actually a pretty short period of time, 15 minutes. So in any case, what's important is that we just let you know that there are some protocols that we're asking you to follow. Actually, first off, though, I just want to ask how you've been feeling. Have you noticed that you've had a higher temperature recently?
No. I mean, honestly, I felt fine. I mean, I had no idea that just being around someone in that short amount of time could be enough to expose me. What can you tell me a time frame on this? I mean, how long have I been possibly exposed? What about my husband? What about my kids?
Well, that actually leads me to the next question, which was if you are living with other people. So right now, well, first off, I'm glad to hear it doesn't sound like you've been experiencing anything different recently. You don't feel shortness of breath or anything else? Okay.
No, only from the stress of this conversation right now, but prior to that, no.
No, and I understand. It can be really jarring to suddenly hear that, to hear this news. So we do understand.
I mean, I have kids in the house. I have my husband. And this is not, I mean, we live in the city. We have very limited space here. Everybody's in close proximity to each other.
No, and we understand. I mean, as far as the fact that you've been in direct contact with someone, we do ask that you try to, physically separate yourself for the next 2 weeks, for the next 14 days. I don't know if you have ways that you can kind of quarantine inside of your room, try to create even physical barriers within your living space, within your own home, to just try and keep a physical distance between you and the other people in your house for 2 weeks. I mean,
is that going to be enough to do that? I mean, the air still circulates.
Well, we ask that you do the best that you can. We know in New York it's not always so easy to do with the smaller living quarters. We are, let's see, pause simulation. Hi, Ben.
Right. Not a problem. That's the whole point. It's very authentic and gets that pulse rate going, doesn't it?
Oh my goodness,
So,
yes. I mean, I'd love to hear from any of the tracers. If you could chat in the box if there's anything.
Actually,
you know what? I think that this is a really great time, Joanne. First off, I applaud you for jumping in there and doing that and being brave. Thank you so much for that. I want to make certain that there's plenty of time for Dr. Mooney to answer any questions, and I think that it's a great time to reflect on what went on in that conversation and maybe what went well and what you could have done differently next time. So I'm going to go ahead and turn you back over, but I'm here if anyone needs me, okay?
Thank you so much, Bennett. And I just wanted to say I was monitoring the chat during your conversation, and I hope I pronounced this correctly, Sahil, who I think is a tracer who's joining us today, said that the conversation is very accurate to an actual difficult case and that you're doing great.
Oh, thank you. That was definitely nerve-wracking, I'll be honest. Like trying to remember what facts you're supposed to give and covering the questions, but then also trying to be present with the person.
It's a very difficult profession. And funnily enough, I recently spoke to like a human resources executive, and they have to start doing contact tracing in their company. And it's incredibly difficult for them to get those kinds of operations up and running because people who, are basically just HR reps are now also sort of moonlighting as part-time contact tracing, like medical personnel. So it becomes a increasingly difficult and sensitive situation in terms of like workplace dynamics, for example.
Yeah, no, that was that really does like put you on the spot. Like I can imagine, like especially if you're suddenly having to be placed in a totally different scenario of going from HR rep to telling people or like asking for medical stuff, like that would be pretty challenging. Wow.
So thank you so much for joining us, Joanne. So it's actually fascinating. The way that immersion works is that we have a human in the loop behind every single one of our simulations, which means that we're able to make the situations quite stressful. Like we can stretch people to a much more significant degree than most other kinds of training tools. I mean, there are very many VR companies and many training companies. We're the only VR simulation tool that's dedicated exclusively to cultivating these human skills. And we do this by taking a human in the loop approach that blends AI and live human interaction. What makes this unique is that by having a human at the other end of each and every interaction that takes place, that interaction is completely unique, unrehearsed, and customizable. So we developed these simulations similar to the one that you've just seen, specifically for use by healthcare organizations, schools, universities, even private corporations across a variety of different types of soft and human skills training. And one second. And the reason that we use avatars is because they address two major bottlenecks in effective role play: scalability and believability. We address scaling because we actually have an amazingly talented pool of simulation specialists. It's to the point that many of them actually work on projects replacing direct service hours for frontline healthcare personnel like nurses or nurse practitioners or PAs who are getting graduate degrees or doing additional forms of training. And these simulation specialists come from quite intensive acting backgrounds. I mean, that part of the company, we call it professional services. They don't interview, they really do audition. While at Immersion, many of them engage in a wide range of stage and television projects. And we leverage this talent into a distributed pool of folks that can deliver 5 times more simulation than hiring, for example, an on-site actor or doing something like having a standardized patient in an office. So there is no downtime between scenarios, between simulation sites, and it means that folks can do it from home. And for example, a distributed team of contact tracers or corporate employees can all receive training like interspersed throughout their day, and they don't need to be pulled out of their day-to-day lives in order to practice these really difficult skills. We also use avatars because it improves believability and learning effectiveness. Immersion came out of a project funded by the Bill and Melinda Gates Foundation called Teach Live, which was actually developed specifically to address this learning effectiveness problem. And the research that we've done with them, as well as with Duke University, shows that learners benefit from the safety and anonymity created by avatars. They open up, they're more fluent, and they speak more words per minute with avatars than with face-to-face role play. Avatars also allow our simulation specialists to portray a wide range of individuals, whether they're 6 or 60 years old, as well as many special populations. This customization really sets Immersion apart. It allows learners to experience working with populations that would be impossible to obtain under any other role-playing settings. So a couple of the areas in healthcare where we're currently at play, I mean, we work with pharmacy and psychiatry providers, general practice, counseling and wellness, pediatric and long-term care. In addition, a lot of the bread and butter of our business is in things like corporate leadership development, teaching project management skills, or even teaching teachers how to better teach students. So generally anywhere where effective role play is necessary in order to teach difficult interpersonal skills that are necessary for success in some kind of high stakes situation, we generally work with somebody on addressing those kinds of issues. And in medicine, there is this concept of, I believe it's see one, teach one, see one, do one, teach one. And that's a dangerous learning strategy in many very, very high stakes situations. And because of that, the simulation approach, because of its parallels and effectiveness to observational learning, it allows for the demonstration of mastery, and students can experience holistic improvement and deliberate practice that allows them to make rapid gains in performance in a personalized and direct way. So let me just take a quick look at the chat.
Can I just say something?
Yes.
Jacob? Just absolutely, it's absolutely fascinating. really interesting. And one of the things I didn't get to say in my presentation is that, until relatively, maybe until like the 1940s, when contact tracing for sexually transmitted diseases became important, people weren't given specific training in this. Usually it was left to people like what were called sanitary inspectors or nuisance inspectors, who were there to monitor and regulate things like like drains and housing regulations and so on. So they weren't actually trained in the kinds of the ways in which the sorts of language that Joanne was trying to employ around understanding and realizing how difficult it is and trying to build a bond. They realized it was important, but they weren't given any specific training in it. So I think this is how it's developed over the last 50 or 60 years ago is really intriguing. And I think this is an absolutely fascinating development.
Thank you so much, Graham. That's very, very insightful, and I really appreciate you sharing that with me and with our community here. And just to sort of go into a little bit of detail about some of the more nuanced work that we do in healthcare right now. We have a lot of avatars for diverse and dynamic learning, including neurodiverse populations, non-native English speakers, at-risk populations, people with physical disability or autism spectrum disorder, like Larissa here on the right suffers from traumatic brain injury, Janice has cerebral palsy, and Thomas suffers from Down syndrome. And we actually develop these avatars in combination with subject matter experts. And they actually have very specific tics and mannerisms and behavior that would be really distinct to these special populations. So the use of virtual simulations actually expands the scope of where people are able to get sort of meaningful clinical experience prior to interacting with some specific community. I'm also going, so I'm going
I noticed I had a question in the chat to interrupt.
Oh, no, please.
Yeah. Well, I've got a question for contact tracers as well when I'm done with this, but the scalability issue around public health in response to COVID. One thing I would say is, well, you could say who predicted this, who could have ever predicted this, but it was kind of predicted. It's just that, it's difficult to imagine even when something happens exactly what needs to be done. So I think the question around scalability isn't whether, it is more about the sorts of, if you like, disaster management planning that's in place previous to anything that happens, and not letting that go out of date, not letting it become stale, imagining the kinds of scenarios around different in relation to infectious disease, different ways in which the disease can be transmitted. There was lots of debate early on about the persistence of COVID-19 on particular surfaces and so on. There's still debate around how close you have to be for it to be transmitted and so on. So that's really important. But being able to imagine that kind of scenario in a disaster planning situation will improve the ability to scale up. So I think that's a really important aspect. But I don't know if that's if that is a. Sorry, I forgot about my camera. I don't know if that is answers your question. So there's that. The other thing, the question I've got for contact tracers, and particular to this slide, and I don't know if I have time to even answer this, but how much do contact tracers find out about other circumstances of their contacts when they're in touch with them? So, for example, do you know if you're talking to a person who has a physical disability? Do you know if they have any kind of other disorder that enables you to contextualize the information, and that would enable you to be even empathetic, competent, structurally and culturally competent in the ways that you need to be when you're doing contact tracing?
So we have a response from two of the tracers that are actually in our audience, Sahil and Catherine. Thank you so much. And they say that these questions are typically a part of the case/contact investigations, and all the time. It depends if they have a physical ability, I'm guessing physical disability, and their proxy or parent will confirm and complete the interview.
Right.
Very, very interesting. So let's see, we ask a separate question if they have underlying medical conditions. For disabilities, sometimes a family member answers. Sometimes we find out, sometimes we can ask our data team to check medical records. Plus we have a team that does all the hospital cases. So it sounds like there are a couple of different ways that this is ordered and structured in different communities throughout the country. So just to push onward, because I see we're approaching the top of the hour, I wanted to also touch upon more broadly some of the work that we've. Oh, I see a question from Priscilla. How long/how many training sessions for the role as a contact tracer? Can Sahil give an overview of the training and what takes place, materials, collateral, scripts, hit perform, etc.? So a lot of the training, I believe you can just take a contact tracing course for free from Coursera. And I believe, Graham, were you involved in the design of that course? Okay.
Nope,
So there is a Johns Hopkins totally free contact tracing course that is available to anyone. And there is also a question of, it seems it depends on the local area. Laura took the Coursera course. She said it was awesome. For us, our training in New Jersey took about 30 hours total, which included Johns Hopkins and a university-specific training. And it seems like there's a lot of on-the-job training.
I think, yeah, that's in the US case. That's one of the things that has been important, the availability of these online courses that is reinforced and embedded in local jurisdictions. It's been very different in other places. I know in the UK, there's been a lot of debate and discussion about the fact that the UK government gave the contact tracing contract to a private company that had no experience with contact tracing, rather than embedding it in the local health authorities and the local health jurisdictions. And that is actually a very interesting comment on the way in which public health has been privatized increasingly through contracting, not contacting, and also the history of local centralization and tensions in the development of public health government. So, these all have very long historical roots.
Fascinating. Let's see if there are any other questions in the chat. Dr. Mooney, how do you think that technology will transform contact tracing in the future?
I think it's a good question. You should never ask a historian to project into the future. It's the worst thing you can do. The way I say, but we can use historical examples. So, for example, so contact tracing, electronic methods of like we've all seen just now in this chat discussion, the way in which you can join up electronic information in ways that weren't possible in the past. Historically, health departments would have had these huge indexing systems with indexing cards of, say, a TB patient and where they lived and what conditions they had and the domestic circumstances. So electronic communications and medical records have enabled some of this information to be meshed together so that it becomes greater than the sum of its parts. I think mobile technologies are going to be really important, and I think there are issues around, issues around confidentiality and maintaining confidentiality and privacy. That's going to be the big thing. But I also think that the responsibility is devolving upon the individuals who use this technology. So you think, in terms of apps and mobile technology. So it's kind of like the shifting of responsibility for who is who takes the not the blame, but who is where the focus is going to be for when these things go wrong is going to be much more on the focus of the individual as it is upon the government or the agency that is providing those technologies.
So, Dr. Mooney, there's another fascinating question in the chat, but just in case folks need to leave us at the top of the hour, I just wanted to tell them what our next upcoming roundtable is and invite them to it. On December 3rd, we're going to be hosting Lisa Desai and Brian Cole from MindWise Innovations Behavioral Health Consulting. And we're actually going to be discussing how soft skills are being leveraged with mental health counseling and intervention during the COVID-19 pandemic. It's becoming increasingly relevant during the dramatic lifestyle changes we've made in the last several months, and that are going to be around at least in the near future. And for anybody that needs to leave at the top of the hour, we most sincerely look forward to seeing you there. So moving on to that question, Dr. Mooney, do you see any parallels between the 1918 Spanish flu and now surrounding contact tracing? Do you think there are things from that time that should be applied today?
That's a very good question, Sahil. Thank you. Thank you, anybody, for sticking around. It's difficult to make a direct comparison in the sense that the public health administrations in 1918 were really stretched because of the First World War. A lot of the medical professionals actually went to the front. They were doing military duties and so on. And so the actual amount of contact tracing that was going on, as far as I'm aware, wasn't as great as perhaps it would have been or should have been. So that's actually an interesting thing to sort of countenance is, our ability to do the contact tracing all depends upon other contexts of what's going on in the world around us. So that's an important thing. I think the other thing is that, a lot of one of the studies that have been done on the historical epidemiology of this have shown that what we call the non-pharmaceutical interventions, the closing of schools, the restricting public gatherings, closing theatres and cinemas and restaurants and faith-based gatherings, places that intervened early and for a long time had much lower case rates and incidence rates than did places that either didn't implement those things or were slow on the uptake. And so I think that was a big lesson that was being put forward in the early parts of this pandemic, is we need to do this early and deeply in order, these social distancing measures. So I don't think there isn't a really good parallel with contact tracing with 1918 influenza pandemic, because the structures were being so stretched because of the First World War. Excuse me. Yes, the John Barry book is excellent, Laura. You're right.
And we're going to need to wrap up soon, but there is one more question here in the chat that I wanted to surface to you. How close are we in the US to doing tracing via cell phones? And are you familiar with the SHIELD program at the University of Illinois?
Don't know the answer to that. I don't know how close we are. So I'm not going to go there, actually. I will say that it requires a lot of, I suspect it may require a level of participation and willingness to participate on behalf of the population that is going to be a challenge. That's where I'll leave it.
All right. Thank you so much for joining us, Graham. It was an absolute pleasure to have you. I've left up the slide for a couple of minutes now. If you have any questions, please feel free to email me at jacob.nicolau@mersion.com or text me. My phone number is right up there on your screen. Feel free to screenshot it if you'd like. We're also going to be sending out a number of different door prizes. We're actually giving away an Apple Watch as a part of this event, and we're going to reach out to it's going to be randomly drawn by one of my colleagues, and we're going to reach out to that person later today. Thank you so much for joining us, and I wanted to once again extend an invitation to join us on December 3rd, where Lisa and Brian are going to be exploring how soft skills are being leveraged in the context of mental health counseling and intervention in our current era. Thank you so much, Graham. And,
Thank you.
and goodbye, folks.
Does that watch have a tracing app on it?